Hello, this is Karen from the California CHC, and I'm here with Nilafar and Ishita, and we're going to present to you our epidemiology project. Social determinants of health in Central Valley type 2 diabetes mellitus patients. So here's our poster in its entirety, and we're just going to break down the individual sections and discuss them for you. Type 2 diabetes is a disorder that's becoming increasingly prevalent not only nationwide but also in California. The California Health Interview Survey states that California alone has almost 2 million adults living with diabetes, and probably even more since many remain undiagnosed and unaware of their diabetic status. The 2012 CDC Diabetes Report Card states that type 2 diabetes accounts for about 95% of diagnosed diabetes in adults. And within the last 20 years or so, the number of new cases of diagnosed diabetes has tripled. Past studies have shown a higher frequency of patients who are diagnosed with diabetes mellitus in the Central Valley of California compared to the state's average. Just statistics for you guys to understand the problems that we face here in Tulare County. The California state average of adults with diabetes is about 7% of adults, whereas in Tulare County we have a higher prevalence with 9.4% of adult population diagnosed with diabetes. Tulare County, where the Family Healthcare Network is stationed, also ranked last out of all California counties in annual hemoglobin A1C testing, with only 66% of patients having their hemoglobin checked annually versus the California average of 83.1% of people getting their hemoglobin A1C checked. Since Family Healthcare Network serves a large patient population in the Central Valley, our clinics provide a unique opportunity to conduct a study to evaluate and assess potential social determinants that influence the disease management of diabetic patients, which could later prime changes to improve diabetes management and efficiency in how state and federal funds are used. While previous studies have identified general social determinants of health, our study aimed to find social factors that contribute to disparity in disease management specific to diabetic patients of the Central Valley. Our research objectives. Previous research has shown that social disparities have a negative impact on healthcare management, but methods for attempting to identify patients with these disparities are largely unavailable. This study examines the effectiveness of our questionnaire in identifying patients with socioeconomic barriers hindering management of type 2 diabetes.
Hi, I'm Nilufar and I'll be presenting the methods and results. For the methods, we developed a 13-question survey. Our goal was to identify socioeconomic disparities in Central Valley in type 2 diabetic patients. To that end, we administered the survey to 88 type 2 diabetics who were 18 and older at Family Healthcare Network. Diabetic control was determined by hemoglobin A1C levels. Levels above 7 were defined as being poorly controlled, and levels at or below 7 were defined as being controlled. On the questionnaire, a positive response meant the patient identified the presence of a social disparity. Spearman's rank correlation coefficient was used to analyze trends between hemoglobin A1C levels and the number of identifiable social economic disparities. For the results, in Table 1, we can see a summary of our data. Each survey participant's data was sorted according to their hemoglobin A1C values. The control group, being defined as previously stated, where patients had a hemoglobin A1C of 7 and below, and the poorly controlled group were defined as having a hemoglobin A1C level above 7. As we can see, there are almost equal amounts of Caucasians in the controlled and poorly controlled groups. Similarly, Hispanics are equally represented in both controlled and poorly controlled groups, with the Hispanics having almost four times more of diabetes compared to the Caucasians. Health insurance is also more prevalent in the controlled group, and mean hemoglobin A1C was lower in the controlled group versus the poorly controlled group, which was expected. Now, the mean positive responses were calculated by taking the total number of positives for each patient. Then these numbers were averaged within each overall group. The key thing to point out here would be that the mean positive responses seem to have a difference between the controlled group and the poorly controlled group. But if you look at the standard deviations, it shows that there really isn't a statistically significant difference between the controlled and poorly controlled groups. Figure 1 and 2 go together, and these look at the data from the Spearman's rank correlation coefficient. The initial calculations were done to find a correlation between the number of positive responses and the hemoglobin A1C. We were hoping that the survey was going to give us data that showed some trend where the number of social disparities in a patient would correlate to how well or poorly controlled their hemoglobin A1C numbers were going to be. Unfortunately, there was no statistically significant correlation, and so that's what we were seeing pretty much in figure 1. What we ended up doing was we used Spearman's rank correlation coefficient as an alternative to the Pearson's linear correlation. Spearman's needed to be used because our data is ordinal. Table 2 goes ahead and shows the Spearman's numbers for our data. As we can see, the Spearman's coefficient came out to be 0.077, and it's barely above 0, indicating that there's a slight correlation between our two variables. The p-value is the hypothesis test calculation. Since our initial alpha level was 0.05 and the p-value that we calculated was 0.4769, we must fail to reject the null hypothesis. Our null hypothesis was that there is no correlation between a person's social disparities and their diabetes status. Figure 2 shows some of the significant things that we wanted to highlight from our study. The main things here to point out are that there's 80% of the people that we surveyed indicated they had at least one social disparity. We also found that 67% of the people surveyed were poorly controlled. If we look at the first column in figure 2 in red, that goes ahead and shows the 80% with the social disparities compared to the 20% in blue that don't have social disparities. The second column shows in red that only 33% of the people had their hemoglobin A1C levels in the controlled range versus 67% that were uncontrolled in blue.
Hi, this is Ashita, and I will be talking about the limitations. So the survey allowed us to see that there is a prevalence of socioeconomic health disparities within the patients of Family Healthcare Network. Again, 80% of those surveyed positively responded to facing a health disparity. Our study surveyed only those seeking care at Family Healthcare Network. How we can expand our study is to follow the various aspects that impact maintaining good health. For example, patients with comorbidities struggle to be overall healthy, or that patients take different combinations or more potent medications to control their diabetes. Most of all, the A1C level is a dynamic number, and the A1C level diagnosed may be different from the current recorded value on the survey. For example, two patients may start off at the same diagnosed level where one improves 2 points, whereas the other improves 4 points. Such information is limited in this study, and such improvement may be dependent on their disparity. So, in conclusion, our study showed that a high proportion of patients have health disparities and that a high proportion have diabetes. Our study aimed to evaluate if our health disparities survey can identify a correlation among patients with poorly controlled diabetes and the number of perceived socioeconomic health disparities. Since our survey was a simple yes or no answer, we could not measure how much each disparity affected that patient. Again, our null hypothesis was that no correlation exists between patients with poorly controlled diabetes and their socioeconomic status. Therefore, we failed to reject the null hypothesis, but that doesn't prove that the null hypothesis is true. Our study did not find such a relationship because, as described by our limits, there is a spectrum of factors that impacts an individual's ability to be in good health, not just their health disparities, and that is what our survey tested. What our study did show is that there is a high percentage of patients at Family Healthcare Network, 80%, that face some level of disparity that is prevalent in the community, and also that a high percent, 67%, have poorly controlled diabetes. It may be that a specific disparity is more indicative compared to the other question items in predicting their control of diabetes, or it may be that health disparities in itself and not the severity of it impacts a person's control of their condition. But such knowledge is beyond this study. So our study did not show to identify patients with poorly controlled or controlled diabetes, but it can be used as a tool for physicians to screen their diabetic patients for any disparities and appropriately educate them to help them achieve good health.
That was our presentation. We thank you very much for your attention and we hope you enjoyed it. From everyone here in California, goodbye.